Do this right now. Place one hand over your chest. Imagine the pills waiting in your morning organizer. Just once. Now notice your pulse, your breath, and your balance. Do you feel steady, heavy, dizzy, or suddenly tired? If that feeling returns after medication, that is the warning sign I want you to notice. A 72-year-old man once stood in his kitchen. Coffee sat beside him. His pill box was open on the breakfast table. It did not begin like an emergency. It crept in quietly. First came fatigue after his morning tablets, then dizziness near the bathroom sink, then ankle swelling, strange bruises, and shortness of breath that everyone called aging, until one ordinary morning turned into a collapse, a stroke workup, and a shocking discovery. The danger was not age alone. It was an overlooked medication burden. Here is what I need you to hear. Common pills after 60 are not automatically safe just because they helped you years ago. They are not harmless because they are common. And taking them with food does not always protect you. Your body does not bruise without a signal. It does not swell, stumble, race, bleed, or weaken for no reason. And the most surprising part is this. The real trigger may not even be in your chest or brain. You may feel the warning as dizziness, black stools, palpitations, sudden weakness, confusion, or swelling. But the signal may be coming from your kidneys, your blood pressure, your clotting balance, or one silent drug interaction. In my 25 years working with older adults and cardiovascular medication safety, I have seen this pattern missed again and again. A senior takes pain pills, stomach pills, blood thinners, cholesterol pills, heart rhythm pills, and blood pressure tablets. Yet no one reviews the whole list together. I am not trying to scare you. Today, I want to help you read that pattern. And we have science behind this. In the New England Journal of Medicine, researchers using United States CDC national emergency data estimated 99,628 emergency hospitalizations each year for adverse drug events among adults 65 and older. Warfarin, insulin, oral antiplatelet drugs, and oral diabetes medicines caused about 2/3. In simple terms, aging bodies handle common medicines differently, and the safest prescription still needs review when kidneys, vessels, rhythm, hydration, and combinations change. In this video, we are counting down 5 pill categories seniors must review before heart attack and stroke strikes. Number 5 looks ordinary, yet it hides in millions of bathrooms. Number 3 is the one families defend because it seems protective. But I am not going to reveal the most important connection yet, because number 1 is the pill mistake that turns several small risks into one emergency. My name is Dr. Thomas Bennett. At Senior Health Daily, my promise is simple. Calm doctor, led guidance, plain language, real research, and practical steps older adults can discuss with their own doctor. Before we go any further, drop a comment below and tell me this. Do you take one daily pill, 2 to 4, or 5 or more? Because your answer to that one question tells me how carefully your medicine list deserves to be reviewed for kidney stress, bleeding risk, dizziness, heart rhythm changes, and blood pressure drops. Write 1, 4, or review in the comments. I read every single one. Now, one important point before we begin. Medication itself is not your enemy. It is part of your body's protection when used for the right reason, at the right dose, with the right monitoring. The problem begins when kidneys filter more slowly. Liver processing changes, blood vessels stiffen, heart rhythm becomes more vulnerable, or dehydration magnifies drug effects. Do not stop any prescribed medication suddenly without medical guidance. So listen, because number 5 is the cause many miss. It sits quietly near breakfast, beside coffee, beside vitamins, beside prescriptions. But after 60, one extra dose, one hidden interaction, or one dehydrated morning changes your risk. And that is when the medicine cabinet becomes where the warning quietly shows up before your body answers loudly. Before we move into number 5, I want you to see the hidden pattern. After 60, medication safety is not just about the name on the bottle. It is about the body receiving that medicine today. The kidney that filters it, the liver that processes it, the stomach lining that tolerates it, the blood vessels that react to it, and the clotting system that must stay balanced. A pill that was reasonable at 50 can become risky at 72 if it is combined with dehydration, a new antibiotic, a weaker kidney number, a fall risk, or another prescription added by a different doctor. This is why I do not ask seniors, "What pill do you take?" first. I ask, "What else do you take with it? How long have you taken it? And what changed in your body afterward? That question saves lives. A composite patient, I will call Martin, 74, from Ohio, believed his pill organizer meant everything was safe. He was careful, he never skipped doses. Yet he felt dizzy after breakfast, tired by noon, swollen by evening, and bruised after small bumps. His family called it age. When his pharmacist placed every bottle on the counter, including pain pills, stomach pills, aspirin, cholesterol medicine, and heart tablets, the pattern finally appeared. The problem was not one evil drug. It was an unreviewed medicine burden. Before we go into the first pill category, tell me your age and the city you are watching from. Are you watching as a senior, a spouse, a caregiver, a son, or a daughter? I am truly happy when you are healthy and happy every day, and this community is here so older adults never feel alone while learning how to protect their heart, brain, and future. The science supports this concern. A New England Journal of Medicine analysis of United States CDC emergency data estimated 99,628 emergency hospitalizations every year from adverse drug events in adults 65 and older, and about two-thirds involved warfarin, insulin, oral antiplatelet drugs, or oral diabetes medicines. That is not rare. That is a national safety signal. So today, do not panic. Pay attention. These 5 pill categories are not automatically bad. Many are life-saving when matched to the right person. The danger begins when dose, duration, kidney function, pulse, bleeding risk, blood pressure, and interactions are never reviewed together. Number 5. Over-the-counter pain pills and NSAIDs. The pill seniors reach for when the knee hurts is often the same pill that pushes blood pressure, kidney blood flow, stomach lining, and bleeding risk into danger. I am talking about ibuprofen, naproxen, diclofenac, and similar non-steroidal anti-inflammatory drugs. Seniors often say, "I bought it myself, so it must be mild." That belief is dangerous. Over-the-counter means easy to buy. It does not mean gentle for an aging body. Here is what happens. NSAIDs block inflammation chemicals, but those same chemical pathways help preserve kidney blood flow and protect the stomach lining. When the pathway is blocked, the body holds more sodium and fluid, blood pressure rises, kidney filtration becomes more vulnerable, and the stomach lining bleeds more easily. Add a blood thinner, aspirin, clopidogrel, prednisone, a diuretic, or a blood pressure medicine, and the risk becomes a combination problem. The American Geriatric Society Beers criteria warns that oral NSAIDs in older adults increase gastrointestinal bleeding, peptic ulcer disease, acute kidney injury, and blood pressure problems. It also reports that upper gastrointestinal ulcers, gross bleeding, or perforation occur in about 1% of patients treated for 3 to 6 months and about 2 to 4% treated for 1 year. Another human evidence anchor is the Danish nationwide BMJ study on diclofenac. Researchers found diclofenac initiators had a 50% higher rate of major adverse cardiovascular events compared with non-initiators, 20% higher than ibuprofen or paracetamol initiators, and 30% higher than naproxen initiators. That does not mean every dose causes a crisis. It means seniors should stop treating these pills like harmless candy. Ask yourself, did your blood pressure climb after you began taking pain pills more often? Did your ankles swell? Did your stomach burn? Did stools become black? Did bruises appear faster? Did you take ibuprofen or naproxen while also taking aspirin, Plavix, Eliquis, Xarelto, warfarin, prednisone, or a water pill? A composite patient I will call Ruth, 71, from Tampa, took naproxen before gardening and again before bed. She believed the pill was safe because her stomach did not hurt, but her blood pressure rose, her ankles swelled, and her kidney number worsened. Her doctor did not scold her. He asked the right question, "How often are you taking this, and what are you taking it with?" That question changed her plan and restored her confidence. Your health is your most precious capital. If this warning makes sense, write one word below. Review. Do not write it because you plan to change medicine alone. Write review because your medicine list deserves a calm, serious conversation with your doctor or pharmacist. Do not stop prescribed medicine suddenly. But do not hide over-the-counter pain pills either. Ask your doctor, is this NSAID safe with my blood pressure medicine, kidney function, aspirin, clopidogrel, Eliquis, Xarelto, warfarin, or steroid? What is the lowest effective dose? How many days is too many? Is a topical pain reliever, Physical therapy, heat, ice, acetaminophen, or another plan safer for me? The next pill is different. It is often prescribed to protect the heart, but protection still needs review. Number 4.
With a clinically
Statins and
proven
cholesterol
formula,
pills.
it works
This
to
pill
keep your
protects
heart
many
and
hearts.
arteries
But
protected.
after 60, the question is whether the dose, muscle symptoms, blood sugar, liver history, and interactions still fit the person taking it. I am talking about atorvastatin, simvastatin, rosuvastatin, pravastatin, and similar cholesterol medicines. Let me be precise. This is not an anti-statin message. Statins reduce heart attack and stroke risk in many people, especially those with prior heart attack, stroke, stent, diabetes, or high vascular risk. The problem is blind continuation without asking whether today's dose still matches today's body. The common belief is, I have taken it for years, so there is nothing to discuss. But after 60, the same cholesterol pill can interact with new antibiotics, antifungals, heart rhythm medicines, grapefruit products, and other prescriptions. Frailty, weight loss, kidney changes, and liver history also change the conversation. A Lancet meta-analysis from the Cholesterol Treatment Trialists collaboration included 28 randomized trials and 186,854 participants, including 14,483 people older than 75. Statin therapy or more intensive statin therapy reduced major vascular events by about 21% per 1 millimole per liter reduction in LDL cholesterol. That is meaningful heart and brain protection. But side effects still deserve respect. The European Atherosclerosis Society Consensus Panel reported serious statin myopathy with major CK elevation at about 1 per 1,000 to 1 per 10,000 people on standard doses, while broader muscle symptoms are reported by 7 to 29% of people in registries and observational studies. The STOMP randomized trial found muscle pain in 9.4% of atorvastatin users versus 4.6% on placebo. In plain language, many symptoms have other causes, but new weakness still deserves evaluation. Ask yourself honestly, did thigh pain, shoulder aching, calf weakness, or trouble climbing stairs begin after a dose increase? Did it appear after a new antibiotic or heart rhythm pill? Has anyone reviewed your medication list for interactions? Has anyone checked whether symptoms fit the timing of the statin or another cause such as thyroid disease, vitamin D deficiency, or muscle disease? A composite patient I will call Samuel, 78, from Chicago, thought his heavy legs were age. He had taken simvastatin for years. Then another medicine was added, and his weakness became obvious. His doctor reviewed the interaction, changed the plan, and kept heart protection in place. Samuel did not walk away afraid of statins. He walked away with a safer plan. If you are still watching and this is helping, comment number 4 below. If you do not like commenting, type 0. I respect quiet viewers too, but that small number helps me know whether seniors want more careful medication review lessons like this. Do not stop a statin on your own. In high-risk seniors, stopping without a plan removes protection your arteries and brain still need. Ask, do I still need this exact dose? Is this for primary prevention or secondary prevention? Should muscle symptoms, blood sugar, liver history, thyroid function, or interactions be reviewed? Is a lower dose, different statin, or add-on medicine more appropriate for my age and current risk? Now, number 3 feels harmless because it is called a protector. Number 3. Proton pump inhibitors and stomach protectors. The stomach protector feels safe because it stops burning. But daily long-term use after 60 deserves a nutrient, kidney, infection, and interaction review. I am talking about omeprazole, pantoprazole, esomeprazole, lansoprazole, rabeprazole, and similar reflux medicines. These drugs have real value. They protect people with ulcers, severe reflux, erosive esophagitis, Barrett's esophagus, and selected bleeding risks. But relief can become routine, and routine can hide the need for a stop-date conversation. The misconception is, if it protects my stomach, it protects me everywhere. No, a stomach pill does not protect kidney blood flow from NSAIDs. It does not erase every bleeding risk. It does not solve aspirin plus blood thinner problems. And it does not automatically stay necessary forever. A JAMA study from Kaiser Permanente examined 25,956 patients with vitamin B12 deficiency and 184,199 controls. 2 or more years of PPI use was associated with vitamin B12 deficiency, with an odds ratio of 1.65, and higher daily dose strengthened the association. A JAMA internal medicine study, led by Johns Hopkins researchers, followed 10,482 participants in the atherosclerosis risk in community study and replicated findings in 248,751 Geisinger Health System patients. PPI use was associated with a 20 to 50% higher risk of incident chronic kidney disease. This does not prove every PPI injures kidneys. It proves long-term daily use deserves review. There is also a major interaction point. The FDA-approved Plavix label says to avoid clopidogrel with omeprazole or esomeprazole because both significantly reduce the antiplatelet activity of Plavix. That matters for seniors with stents, stroke history, or vascular disease. Ask yourself, have you taken a reflux pill every morning for months or years without asking why? Do you have numbness, tingling, anemia, low magnesium, muscle cramps, diarrhea after antibiotics, or new kidney concerns? Are you taking clopidogrel and a stomach pill that was never reviewed together? A composite patient I will call Helen, 80, from Manchester, defended omeprazole because it stopped the burn. She did not know her B12 was low, and she did not know her clopidogrel needed an interaction review. Her small safe change was not quitting overnight. She brought the bottle to her pharmacist, asked for a step-down discussion, and left feeling respected instead of dismissed. If this community gives you value, subscribe to help it grow, and leave a like so more older adults receive useful medical information. A happy senior community grows when your comment helps someone else feel less confused. And I am grateful every time you share your experience here. Do not stop a PPI suddenly if you have ulcer bleeding history, Barrett's esophagus, severe reflux, or antithrombotic protection needs. Rebound acid and bleeding risk require a guided plan. Ask, do I still need this daily? Can we step down safely? Should magnesium, B12, iron, kidney function, or anemia be checked? Does this interact with clopidogrel? What was the original reason for starting it? The next medicine does not work in the stomach. It works on the pulse. Number 2, beta blockers and certain heart or blood pressure pills. This pill can calm the heart. But when the pulse becomes too slow, a senior often calls it aging, anxiety, poor sleep, or weakness. I am talking about metoprolol, atenolol, carvedilol, bisoprolol, propranolol, and related heart rate lowering medicines. I also want seniors to include rhythm drugs and blood pressure drugs in the same review conversation when dizziness, fainting, fatigue, low pulse, shortness of breath, kidney changes, or falls appear. Beta blockers block adrenaline signals. That can protect the heart after certain heart attacks, help selected heart failure patients, reduce angina, and control some rhythm problems. But the same brake that protects the heart can become too strong when an older adult is dehydrated, underweight, frail, taking several blood pressure pills, or developing conduction disease. A Canadian Geriatrics Journal review from University of British Columbia, researchers identified 25 studies of heart failure therapy in very elderly adults, and adverse drug events were reported in 13 of 23 studies. Bradycardia, hypotension, and syncope from beta blockers occurred more often than expected in younger populations. Another analysis published in the British Journal of Clinical Pharmacology used data from 2 prospective cohorts involving more than 10,000 older individuals. Overall, beta blocker use was not linked to higher fall risk, but non-selective beta blockers were associated with a 22% increased fall risk, with a hazard ratio of 1.22. Type matters, dose matters, pulse matters. Ask yourself, is your resting pulse often below 55? Do you feel dizzy after standing? Are your hands cold? Do you feel unusually tired after the morning dose? Have you had a near fall in the bathroom? If you have diabetes, does low blood sugar feel harder to recognize because the racing heart warning is muted? A composite patient, I will call George, 74, from Toronto, believed he was losing stamina. His pulse was 48 at breakfast. He held the wall on the way to the bathroom. The pattern was not laziness. It was timing, pulse, dose, and medication stacking. His doctor checked sitting and standing blood pressure, reviewed rhythm, and adjusted the plan. George felt safer within days because he understood what to track. Now I want to hear your story. If you have ever felt dizziness, weakness, swelling, bruising, muscle pain, stomach trouble, or strange fatigue after a medicine was added, share what happened in a longer comment if you feel comfortable. I truly respect your story, and your experience can bring real benefit to this senior community. Do not stop a beta blocker suddenly. Sudden stopping can trigger rebound fast, heart rate, higher blood pressure, chest pain, or serious rhythm trouble in some people. Ask your doctor, why am I taking this now? What pulse is too low for me? Should I check sitting and standing pressure? Could this explain dizziness, fatigue, falls, cold hands, shortness of breath, low mood, or masked low blood sugar? Does it interact with other heart, rhythm, pressure, or diabetes medicines? Number 1 is the pill many seniors fear stopping. They are right to respect it. Number 1. Blood thinners and antiplatelet drugs. The most frightening pill is not always the one that causes pain. It is the one that prevents a stroke while making bleeding signs impossible to ignore. I am talking about warfarin, apixaban, rivaroxaban, dabigatran, edoxaban, clopidogrel, prasugrel, ticagrelor, and aspirin when used for clot prevention or combined with blood thinners. These medicines save lives. They prevent strokes and atrial fibrillation, protect stents, and treat dangerous clots. But they require a plan. The misconception is, if one blood thinner protects me, adding aspirin or a pain pill gives extra protection. That thinking sends seniors to emergency rooms. More clot prevention is not always better. Your body needs balance. When clotting is blocked too strongly, black stools, red urine, nosebleeds, head injury, or one small ulcer becomes serious. The BAFTA randomized trial studied 973 people aged 75 and older with atrial fibrillation. Warfarin reduced the yearly rate of major stroke, arterial embolism, or intracranial hemorrhage to 1.8% compared with 3.8% on aspirin, while major bleeding rates were similar at 1.9 versus 2.0% per year. That proves anticoagulation can protect older adults when chosen correctly. The NEJM Aristotle trial found major bleeding occurred at 2.13% per year with apixaban, compared with 3.09% per year with warfarin, a hazard ratio of 0.69. Again, this is not safe versus dangerous. It is individualized risk, kidney dose, age, weight, interaction review, and a bleeding plan. The FDA-approved Eliquis label warns that drugs affecting hemostasis increase bleeding risk, including aspirin, other antiplatelets, other anticoagulants, heparin, thrombolytics, SSRIs, SNRIs, and NSAIDs. That is why aspirin plus blood thinner plus ibuprofen is not a casual combination after 60. Ask yourself, have you had nosebleeds that last longer than usual? Black stools, red urine, vomit that looks like coffee grounds, sudden severe headache, new weakness on one side, a fall where you hit your head, large bruises without clear injury? Are aspirin and a blood thinner coming from different doctors? A composite patient, I will call Maria, 82, from San Diego, carried apixaban in her purse and kept aspirin in a kitchen drawer. She thought baby aspirin was too small to matter. After a hallway fall, she almost stayed home because she felt embarrassed. Her daughter called for medical advice because head injury plus blood thinner is never something to guess about. The lesson was powerful. The medicine was not the villain. The missing fall plan was the danger. Share this video with one senior, spouse, neighbor, or caregiver who keeps a pill organizer on the table. Also turn on notifications, because this channel continues to release useful medical knowledge for older adults who want longevity with safety, clarity, and confidence. Do not stop a blood thinner or antiplatelet suddenly without medical supervision. Stopping can increase stroke, clot, stent blockage, or another serious event. Ask, what bleeding signs mean emergency care? What should I do after a fall? Is my kidney function checked for dosing? Should I avoid NSAIDs, aspirin, certain supplements, or alcohol? What is the plan before dental work, colonoscopy, injections, or surgery? Now connect the 5 together. This is the stacking problem. One pill rarely tells the whole story. An NSAID raises blood pressure and stresses kidneys. A diuretic lowers fluid. A blood pressure drug relaxes vessels. A beta blocker slows pulse. A PPI hides stomach symptoms. A statin protects arteries but deserves interaction review. A blood thinner reduces clotting. Separately, each decision can make sense. Together, The aging body carries a heavier burden. That is why one simple remedy fails. Drinking more water will not fix a bleeding interaction. Taking a stomach protector will not erase NSAID kidney strain. Cutting salt will not correct an overly slow pulse. Taking a supplement will not solve a list that no pharmacist has reviewed. A composite patient I will call Daniel, 79, from Denver, had 5 bottles beside his coffee. His wife noticed he was worse on days he took ibuprofen for back pain. He also took a beta blocker, a diuretic, a blood thinner, a statin, and a reflux pill. The wrong belief was that each symptom belonged to a separate disease. The pattern was stacking. His pharmacist helped create a 7-day timeline. Dose, time, symptom, pulse, blood pressure, pain pill use, stool color, bruising, and dizziness. Daniel did not become medicine-free. He became medicine-aware. Caregivers, listen closely. Your parent may not mention black stools because they feel embarrassed. They may hide dizziness because they fear losing independence. They may keep aspirin because a neighbor said it protects the heart. Ask gently. Do not accuse. Bring the bottles together. Make sure you are subscribed and write your deepest question for the doctor below. I promise to read every comment, and I truly value this senior health community. Older adults here are grateful when you share your experience and ask a thoughtful question, because one question can help many families. Here are the red flags. Call emergency services or seek urgent care for chest pressure, sudden shortness of breath, one-sided weakness, facial droop, trouble speaking, sudden confusion, fainting, black tarry stool, vomiting blood, red urine, severe sudden headache, a fall with head impact while taking a blood thinner, uncontrolled bleeding, very slow pulse with dizziness, or swelling and breathlessness that worsen quickly. Do not wait for a routine appointment when danger signs appear. For persistent but non-emergency symptoms, book a medication review when dizziness, fatigue, swelling, bruising, muscle pain, reflux pill dependence, memory changes, falls, or blood pressure swings continue or worsen. Now here is your action plan. Tonight, do not change pills by yourself. Place every prescription, over-the-counter medicine, vitamin, supplement, herb, eye drop, cream, occasional pain reliever, and stomach pill in one visible place. Include the pills you take only sometimes. Those are often the missing risk. Tomorrow morning, write the time you take each medicine. Then record pulse, blood pressure if you have a monitor, dizziness, swelling, unusual tiredness, bruising, stomach symptoms, bowel color, and pain pill use. This week, ask your doctor or pharmacist for a medication safety review after 60. Use those words. Ask, why am I taking this? What problem is it treating? How long do I need it? What happens if I miss a dose? What side effects matter at my age? What should we monitor? Does it interact with anything else? What symptoms mean emergency care? Can we reduce, replace, or stop it safely if it is no longer needed? For 2 weeks, track one trigger, over-the-counter pain pill use. Record every day you take ibuprofen, naproxen, diclofenac, or aspirin for pain, and write what happened to pressure, swelling, stomach, bruising, stool color, dizziness, and pain. Long-term, repeat the review every 6 to 12 months, and every time a hospital, urgent care, dentist, specialist, or new doctor adds medicine. Bring the containers, not just the names. Seniors often say, the small white one, the blue one, or the stomach one, and that is not enough for safe decisions. The label shows dose, instructions, refill pattern, prescriber, and pharmacy. Also bring hospital discharge papers, because many medication duplications begin after a hospitalization when the old list and the new list are never reconciled. Ask one practical question at the end of the visit. Can you print my current medication list so I can keep the correct version on my refrigerator? That paper helps emergency workers, caregivers, dentists, and specialists see the same truth. If you live alone, place a copy in your wallet and another near the pill organizer. If a caregiver helps you, choose one person to update the list after every appointment. This is not about losing independence. It is about protecting independence. A clear medication list prevents guessing, and guessing is where many avoidable emergencies begin. Keep the plan simple enough to repeat, because a safety routine only works when it fits real life. When the list is clear, The doctor can protect the medicine that helps you and question the medicine that no longer fits your body today before trouble starts quietly. What topic do you want me to explain next? Blood pressure pill timing, blood thinners and falls, cholesterol pill symptoms, reflux medicine review, or safer pain control after 60? Tell me below so I can choose the next lesson that serves you best. Now correct the myth. The myth says natural remedies erase medication risk. They do not. Ginger, turmeric, garlic capsules, fish oil, ginkgo, alcohol, and high-dose supplements can interact with blood thinners, surgery plans, bleeding risk, blood pressure, and blood sugar. Another myth says a stomach pill protects you from every pain pill danger. It does not protect kidney blood flow, heart failure risk, blood pressure, or every bleeding risk. And the most common myth says, if my doctor prescribed it once, I never need to ask again. After 60, review is responsible care. These pills are not evil. Many save lives. Pain pills reduce suffering when used carefully. Statins protect arteries in the right person. PPIs protect the stomach in the right situation. Beta blockers calm the heart when the reason is clear. Blood thinners and antiplatelet medicines prevent strokes and clots when chosen and monitored correctly. The danger is taking them blindly. Number 5 was NSAIDs. The question is blood pressure, kidney function, stomach lining, and bleeding combinations. Number 4 was statins. The question is dose, muscle symptoms, blood sugar, liver history, and interactions. Number 3 was PPIs. The question is long-term need, B12, magnesium, kidney function, and clopidogrel. Number 2 was beta blockers and heart pressure pills. The question is pulse, dizziness, falls, fatigue, and timing. Number 1 was blood thinners and antiplatelets. The question is bleeding signs, fall plan, kidney dosing, surgery planning, and unsafe combinations. This is not just aging. This is medication physiology. And physiology can be understood. Your weekly plan is simple. 1 bag, 1 list, 1 symptom timeline, 1 pharmacist or doctor review, 1 honest conversation before the emergency. Make sure you are subscribed because a related video is coming soon on the most dangerous blood pressure medication timing mistakes after 60, including the morning dizziness pattern many seniors ignore. That next video is very important, and you will want to see it before your next medication review.